All right, let's take a look at the gross anatomy of kidneys. The hilum is the slit. You have renal sinuses, which are a cavity with vessels and urine collecting structures. You have the renal cortex, which is this outer zone, extension of cortex towards the sinus. You have the renal medulla, which is the inner zone, renal pyramids, each with a renal papillae. Urine collecting structures, one minor calyx per pyramid. Two or more minor calyxes form a major calyx, and the major calyces merge to form a renal pelvis. And the renal pelvis will dump into the ureter. Renal plexus of nerves and ganglia wraps around the renal artery, so nerve fibers go to the blood vessels and convoluted tubules of the nephrons, and this includes sympathetic, parasympathetic, and pain fibers. So let's take a look at this nephron again. The renal corpuscle is a structure that includes the glomerulus and the Bowman's capsule. So if you had a question that said, what two structures make up the renal corpuscle, that would be the glomerulus and the Bowman's capsule. It's also known as the glomerular capsule. But let's say blood is coming in here, and remember, look at the size of the afferent. It's a lot larger, so what it does is it pushes, the pressure builds up in here, and then the blood plasma will be pushed out here, okay? And anything that is pushed out here, or there'll be sodium, potassium, pharmaceutical drugs, hormones, urea, ammonia. But that doesn't mean that you're going to pee it out, because like I mentioned, the nephrons and the kidneys are very stingy. Now, what doesn't get pushed out will return via the efferent arteriole and then back into circulation here. Okay. Now, let's say the urinary filtrate. Again, that's what it's called when the glomerulus pushes it out of the capillaries. It's going to go through this proximal convoluted tubule, and like I mentioned, if there's any ions, if there's water, if there's anything that the body says, you know what, we still need, it'll seep out and it'll recollect it. And you have these capillaries that are intertwined here, and they'll pick it up. But let's say it goes down to the descending loop and there's a lot of water in here. Well, the body says, you know what, I don't need to pee all that much out. Let me take some of that water out. Let me take some of that sodium out. And then I'll go down to here to the ascending loop. Now, like I mentioned earlier, loop diuretics will keep the sodium inside, and if the sodium is inside, the water will be drawn to it, and then it'll go out and you'll pee it out. So that's how diuretics work. Well, let's say you're not on loop diuretics and you don't need to be on diuretics. Well, then, while it's going through this, maybe the water gets reabsorbed, some of the sodium might get back, some of the glucose might be. Again, it will only pee out what it doesn't need. Okay, so it's very, very efficient. And again, if you look at this, here's the cortex. The cortex will usually have the nephron itself. It'll have the proximal convoluted tubule and the distal convoluted tubule. So in the medulla, you'll only see the nephron loops and the collecting ducts in the medulla. So that way you can separate these two layers, what's seen in the cortex and what's in the medulla. Again, here's the afferent. So glomerular filtration creates a plasma-like filtrate in the blood, right here. Tubular reabsorption removes useful solutes from the tubular fluid, returns them to the blood. So again, it returns water, other solutes, sodium, potassium, calcium, you name it. It'll return it to the blood. Okay. Tubular secretion removes additional waste from blood, adds them to the joint. So let's say there's some waste that forgot to go here in the eat, and we'll say, okay, let's get rid of this. So it might get rid of excess sodium, might get rid of excess. So you still have a chance for it to kind of go back into the system. Water conservative removes water from urine and returns it to blood, concentrates waste. What is urine? Well, it's 95% water and 5% solutes. Most of it nitrogenous waste, which is urea from the amino acid breakdown, which is the largest solute component. You get uric acid from nucleic acid metabolism. You get creatinine, metabolite of creatine phosphate. But other solutes, you can get sodium, potassium, you name it, calcium, magnesium. Abnormally high concentration of any constituent or abnormal components such as blood proteins, white blood cells, and bile segments may indicate pathology. So that's why you would do a urinalysis and say, what else is going on? What else do you have in your urine? Mostly 95% water and some solutes here, but if you find white blood cells, you might have a urinary tract infection. So, like we talked about earlier, what color is your poop? That tells you what's going on inside. Well, the color of your pee will tell you what's going on inside as well, and see how healthy your kidneys are. So a lot of you, walk around campus with these huge bottles of water, and you don't need that much water. So let's break it down. If your pee is clear, you're drinking way too much water. So it shouldn't be clear. It shouldn't look like water. Okay, so it should be light lemonade. Okay, like a pale straw color. You're healthy, well hydrated. Okay, transparent yellow, that's fine. You're normal. Even a dark yellow, you're going to be dark yellow in the morning because you went 6 or 8 hours without drinking any fluid, so you're going to be dark yellow. But you should probably drink a glass or two as soon as you wake up to hydrate. If it's amber or honey color, really yellow, dark, well, guess what? You're dehydrated. You better drink some water now. Drink 3 or 4 glasses right now. If it's brown, you may have liver disease, severe dehydration. If it's cloudy, you might have urinary tract infection. So if you get cloudy urine, you have to be careful. What if it's red? This is the one that we don't like. But what if you ate a whole bunch of blueberries, rhubarb, or beetroot? Well, that can cause that. If not, you may have blood in your urine, which could be a sign of kidney disease, tumors, UTIs, or some kind of prostate problem. If it's orange, you may not be drinking enough water. You could have a liver or bile duct condition. These colors, we need to get to the doctor as soon as possible. So anytime you see pink, orange, blue, or green urine, yeah, you can have blue or green urine, this rare genetic disease that turn your urine blue or green. Also, certain bacteria can cause this infection. It may be a food dye in something you ate, but if it continues to have green or blue, I'd get that checked out. Now, sometimes your pee will be this neon color, and the reason that's neon color is that you take these multivitamins, and usually it's the B vitamins. If you take a whole bunch of B vitamins, you'll pee neon. So a lot of people that take too many vitamins, and we mentioned this, sometimes we end up taking too many vitamins, and well, guess what? Your liver and kidneys will just filter that out, and you'll just pee it out. Purple, no such thing, so you better not have purple urine. And then what if it's foamy or fizzy? Well, that's a hydraulic effect, if occasional. If you hold in your urine a lot, and then all of a sudden you go, a lot of pressure coming out, so you might get that. But if it continues, you might have excess protein in your diet, or maybe a kidney problem. So if it continues to stay fizzy, you might want to check out. So the bottom line, if it's red, pink, orange, or blue, get that checked out. If it's clear, you're drinking too much water, back off a little bit, but you can be any shades of yellow right here. Once they do a urinary analysis, if they find glucose, you might be diabetic. If you have proteins, sometimes the non-pathological, well, you might have worked out really hard, or you're pregnant, you might have some protein in your urine. But pathological, if you get over 150 milligrams per day, you might have glomerulonephritis, you might have high blood pressure, you might have heart failure, or it might be the first stages of renal disease, so you're going to get that checked out. Ketone bodies, excessive formation, accumulation of ketones, as in starvation, untreated diabetes, hemoglobin, various transfusion, hemolytic anemia, you might find hemoglobin with severe burns, bile pigments, you might have some kind of liver disease or obstruction of bile ducts from liver or gallbladder. If you have erythrocytes, which are red blood cells, well, you might have a urinary tract infection, you might have some kind of trauma, kidney stones, or cancer. And if you have pus, which is leukocytes, pyorrhea, you might have a UTI as well. So, again, the urine clear. Cloudy may indicate urinary tract infection. Pale to deep yellow is urochrome. Yellow color deepens with increased concentration. Abnormal colors are pink, brown, or smoky. Can be caused by certain foods. If you eat asparagus, you know that your urine stinks. It's an enzyme in asparagus that you can't break down. And basically you just pee it out and causes that nasty odor. Okay. Slightly aromatic when fresh. Sounds like we're describing some kind of food. Yes, slightly aromatic. It does develop ammonia odor when upon standing as bacteria metabolize urea. And contrary to what you've been told, you cannot pee on a jellyfish sting or some kind of bite, and the whole premise was that you saw that Friends episode, but also you have urea and you have ammonia in your urine, and basically that should help with the sting. But guess what? Most of your urine is 95% water, so you don't have enough urea or ammonia per that. Say that would be the best concentration in order for you to help that sting. So don't pee on it. Get to the doctor right away. Disease may alter smell. Patients with diabetes have an acetone smell to the urine. pH, urine is slightly acidic, or a pH of 6. Acidic diet, protein, whole wheat can cause drop in pH. Alkaline diet, vegetarian, prolonged vomiting, UTIs can increase your pH. Specific gravity, ratio of mass substance to equal or greater water, don't worry about that. Again, the renal corpuscle is two things, the glomerulus and the Bowman's capsule. You have these podocytes, which are small little cells that wrap around the capillaries of the glomerulus with these foot, and basically they have filtration slits are between the processes. After passing through filtration membrane, filtrate collects in the capsular space. Again, you have this filtration membrane, the capillary endothelium basement. It's kind of like the best way for me to describe it is if you have these cheese, those cheesecloths, and you're trying to strain some stuff, and you're trying to push that through that little cheesecloth, and basically you get what large particles that can kind of stay back, but you get this fluid that can strain through that cheesecloth. So basically you can think of the glomerulus capillaries like that. So here they are again. Here's the afferent, which is the thicker one. Increases the pressure right here. Here's the blood, and then it's going to get, because the pressure is high, it's going to basically produce this urinary filtrate right here, and then it's going to go to the proximal convoluted tubule. So what's in this urinary filtrate? Like we mentioned, ammonia, urea, water, mostly sodium, calcium, magnesium, sugar, you name it, and hormones, pharmaceutical drugs that you've taken. Okay. What are some words? Urethritis is inflammation of the urethra. Cystitis is inflammation of the bladder. Pyelitis is inflammation of the kidneys. Symptoms: dysuria means painful urination, urinary urgency and frequency, fever, and sometimes cloudy or blood-tinged urine. Back pain when kidneys are involved. And how do you treat most UTIs? It's with antibiotics. The drug of choice is usually Cipro, 500 milligrams twice a day for 4 to 6 weeks, because the penetration rate of Cipro or antibiotics into the bladder is very poor, especially men into the prostate, so they have to take it for a longer period of time, especially if you have chronic UTIs, and a lot of women have chronic UTIs. Unfortunately, with that, your side effect of that is yeast infection, so it's not good. Take some probiotics with it. Now, the people that take probiotics with it, they see the Cipro will still kill that probiotic, but you're still replenishing that flora. Here's the structure of the glomerulus. Here's the renal tubule, the proximal convoluted tubule, nephron loop, descending loop of Henle, ascending loop of Henle. Types of nephrons: you have some cortical ones that are short, and then you have the juxtamedular, which are long. The distal convoluted tubule, you have collecting ducts, you have intercalated cells, principal cells, you have a papillary duct. So here's this juxtaglomerular apparatus that's usually found right here. You have a macula densa and mesangial cells that will help. Okay. You have two ureters, tube that extends 25 centimeters from the kidney to the bladder. The ureter is three-layered mucosa, has the urothelium. Muscularis has multiple layers of smooth muscle. The inner muscle is longitudinal. Next layer is circular. Outermost layer of the lower urethra is longitudinal muscle. You emerge from the GI tract. It has 4 layers. The ureter only has 3 layers. Adventitia is connective tissue binding the surrounding organs. So remember, the GI tract has a mucosa, submucosa, muscularis, and serosa, or adventitia in the esophagus. But the ureters only have mucosa, muscularis, and adventitia. Here's the urinary bladder, transitional epithelium. So the 2 ureters dump into this, and they form this little trigone. You have the detrusor muscle on the layer of the bladder that expands. Rugae, remember you have rugae in the stomach. You have these wrinkles of mucosa to increase the surface area. Here's the trigone right here, triangular region on the floor of the bladder defined by 2 ureter inlets and 1 urethra outlet. So here's the urethra, internal urethral sphincter, smooth muscle at the bottom of the bladder, right here. External urethral sphincter at the pelvic floor. So you learn to control the external urethral surface. You cannot control the internal urethral sphincter, because by the time it reaches about 250 mLs, then it reaches a signal to the brain that says, hey, you gotta pee. As the older you get, this becomes more difficult to control, and the younger little kids, that's why they have to wear diapers, because they haven't learned to control their external urethral orifice just yet. The female urethra is short tube anterior to the vagina, so that's why you're more prone to UTIs. The male urethra has 3 divisions. You have a prosthetic urethra, membranous urethra, and then the penile urethra. So males share the urinary tract and the reproductive tract. As you get older, kidneys atrophy with age, become less efficient. Reduced renal function means drugs are not cleared from the body as quickly, so the dosage must be adjusted. So that's why with older patients, you have to be careful. They take a plethora of medicines anyway. They probably take, sometimes a patient would come in, they'll take in about 10 to 12 medications. And if their kidneys aren't working as well as they should, guess what? A lot of those drugs stay in the system because they're not peeing them out. So then you get side effects and they build up. Okay, so they should be encouraged to drink plenty of water. And then, as we know, the elderly are notoriously bad for drinking water. They lack that mechanism of thirst, and they just don't drink enough water. So a lot of their symptoms are due to this. So it just builds up, builds up, builds up. Kidneys become sensitive to antidiuretic hormone. Water balance becomes precarious. The bladder control becomes problematic, and then you get urinary retention and urinary incontinence. So all sorts of problems. UTIs can be caused by improper toilet habits, such as wiping back to front, right? When you want to wipe back front, you're introducing E. coli to the urethra. After defecation, short urethra females can allow fecal bacteria to easily enter, so you should definitely practice good hygiene before and after sex, going to the bathroom. Most UTIs occur in sexually active women, so 40% of women get urinary tract infections. What does intercourse do? Well, it drives bacteria from vagina and external genitalia towards the bladder. So the other thing is, use a spermicide seems to magnify this problem. So a lot of women have a reaction to the spermicide, so try not to use spermicides. Always use a raincoat, but maybe not use one with spermicides. Embryonic development in the urinary tract. Again, we have always mentioned taking care of yourself during the first trimester, because all these organs are important in developing. And when we do human development, we'll talk about the stages of baby development here. Here's the nephrons. Again, these are some disorders of the urinary system: acute glomerulonephritis, autoimmune inflammation of the glomeruli, hydronephrosis, increase in blood pressure, nephroptosis, which is slippage of the kidney to abnormally low position. Floating kidney occurs in people with too little body fat to hold the kidney in place, but this can also happen with truck drivers, people that ride horses, and motorcyclists, so that constant vibration can cause that. Nephrotic syndrome, excretion of large amounts of protein, and then urinary incontinence, inability to hold urine. This might occur as you get older. Involuntary leakage from the bladder. Ladies, sometimes if you go on a jog or a run, you might get this, so work on those Kegels. During pregnancy, this can happen as well, because the little critter is pushing his foot onto the bladder. Can result from incontinence of urinary sphincters, bladder irritation, pressure on the bladder during pregnancy, obstructed urinary outlet, so constantly full and dribbles. Uncontrollable urination due to brief surges in bladder pressure, coughing or sneezing, that's called stress incontinence. Okay. All right. Whoa, that was a lot.